Should we be worried about a newborn if a mother had super high blood pressures during the pregnancy? What if she had high sugars all the way during the pregnancy because of poorly controlled gestational diabetes? Well, that's what we're going to be covering today. What are the fetal effects from 4 very common pregnancy issues? I'm Dr. Tala and I've been a neonatologist for 17 years now. And today we're going to be covering the fetal effects from gestational diabetes, pregnancy-induced hypertension, prolonged premature rupture of membranes, especially prolonged, and maternal anxiety and depression. If you have any interest in helping us choose which video we're going to film next, then please join our channel membership. Right, let's start with 1, gestational diabetes. About 5 to 9% of pregnancies are complicated by gestational diabetes. So basically, during your career, you're going to see hundreds and thousands of infant of diabetic mothers. That's what we call them, infants of diabetic mothers. We shorten it to IDMs. How are these babies affected? If the mothers have high sugars, so relatively uncontrolled gestational diabetes, but high sugars during the pregnancy, then those high sugars will cross the placenta and the fetus will have high sugars during the pregnancy as well. It's estimated that the fetal sugars are about 80% of the maternal sugars. But realize, even though the mother's sugars can cross through the placenta, the mother's higher insulin level is unable to cross through the placenta. So the fetus sees these high sugars, and what does the fetus do? Well, the fetus's pancreas starts producing more insulin to try to lower those sugars in the body. In addition to being the hormone that lowers blood sugars, or basically encourages the cells to kind of suck up the glucose from the blood, insulin is also a very potent growth factor. So if babies have really high insulin levels in their bodies, then they are also going to grow much larger, which is why a lot of these babies are LGA, or large for gestational age, which, as you know, means that their weight is above the 90th percentile for their gestational age. Just being LGA puts these babies at increased risk for a bunch of things. First of all, they're at a higher risk of needing a C-section because we're just worried that the babies aren't going to be able to be delivered vaginally. They're just going to get stuck and not get out. So having macrosomia, or LGA fetally, is enough of a reason to deliver these babies by C-section. These babies are also at a higher risk of getting HIE, or hypoxic ischemic encephalopathy. And really that's for 2 reasons. The first one is, for want of a better description, they could have just kind of outgrown their placenta. So these large babies also might just not be getting kind of enough oxygen from the placenta in the first place, plus a little bit of a stressful delivery is going to increase their risk for lacking oxygen during the delivery process. Also, just because they're so large, they might just get stuck coming out during the delivery process, whether they can get their head out and then they're unable to extract the rest of the body, or they get shoulder dystocia or anything. So obviously an LGA baby is at increased risk of having HIE. And then logically, an LGA baby is at increased risk of having a birth trauma. So something like a fracture, especially like a clavicular or a collarbone fracture, or like in a shoulder dystocia especially, the nerve roots could be pulled and they could end up with like rupture or tearing or bruising of the cervical nerve roots, and so they can end up with like an Erb's palsy or a Klumsky's paralysis. The main reason, though, that infants of diabetic mothers are admitted to the NICU is for hypoglycemia, or low sugars in the babies. And this is really logical if you think about it, because the babies are born with high circulating levels of endogenous insulin. So their pancreas is still spurting out lots of insulin because they've been used to seeing these higher glucose levels during the pregnancy. But what happens after birth? Even if the baby is eating pretty well, then generally it's not going to get enough sugars, and the insulin is going to suck the sugar out of the blood into the cells, and these babies can end up with really low sugar levels. Often these babies are in the newborn nursery, and even if they're eating pretty well and we're supplementing them with donor breast milk or formula, even if we're giving them glucose gels, sometimes their glucose levels just stays really low, and we do have to admit them to the NICU for IV fluids or a continuous dextrose infusion directly into the bloodstream. The insulin is so good at sucking up that glucose from inside the bloodstream that these are often the babies that end up needing a much higher glucose infusion rate or a much higher load of glucose to keep their sugars up. So we could be marching up on the glucose concentration. And remember, if you go above D12.5, then the baby needs a central line, preferably a UVC, an umbilical venous catheter. But these are often babies that need a high concentration of dextrose and sometimes a high rate just to keep the sugars normal in the babies. In infants with no other issues, the insulin levels will slowly start coming down over a few days and we'll be able to wean off the IV fluids until hopefully the baby is off IV fluids altogether, is eating well, the sugars are stable, and the baby can go home. Interestingly, IDMs are also just not great feeders. They're always kind of like a little bit pokey. We always joke that maybe the baby's got the glucose so easily during pregnancy that they really don't want to have to work for it. So sometimes, even after we get these babies off IV fluids, they have to stay in the NICU a little bit longer, literally learning how to eat enough. Sometimes we just have to gavage them a bit, even though they're like big, sometimes term babies. IDMs can also have their parathyroid axis thrown off. So these babies may have transient, at least, hypocalcemia. So if you do have an IDM who is jittery, obviously check the sugar level because, as you all know, hypoglycemia can cause jitteriness, and we worry that if babies are really jittery, then those are the ones that are increased risk of getting seizures. So a jittery baby, obviously check the sugar level, but especially in an IDM, make sure that you are also checking a calcium level because a low calcium can also end up with a jitteriness. Often these babies will have to be replaced with calcium and sometimes magnesium as well. Infants of diabetic mothers are also at increased risk for other reversible issues like TTN, transient tachypnea of the newborn, RDS, respiratory distress syndrome. So these are the babies who are like the massive 37 weekers that have like seemingly air bronchograms and haziness on the x-ray and actually need surfactant, even though they look like they're way too big to actually need surfactant. And they're also at increased risk of having septal hypertrophy, which is basically thickening of the interventricular septum in the heart. All of these are reversible. They just kind of need support through them as well as time. We did film a full video on IDM, so go watch that if you do want more details about all those things. The last thing that I want to say about, one of the last things I want to say about gestational diabetes is to point out the differences between gestational diabetes and pre-gestational diabetes. Gestational diabetes normally develops in the second trimester. That's normally when the sugars start getting elevated in mothers that are predisposed to it. Pre-gestational diabetes, exactly like it sounds, is the mothers who were diagnosed with diabetes before the pregnancy, whether it was diabetes type 1 or type 2, for the extent that those terms are still used. As you all know, all the organs in the fetus are formed in that first trimester, in the first 12 weeks, really. After that, they're all just developing and growing. So if the mother did have really high sugars before pregnancy, as well as in that first trimester, then there's a much higher risk of having abnormal organ or system formation. High glucose levels are known to be embryotoxic. So if the developing fetus is exposed to really high glucose levels, there's a much higher chance that something is going to go wrong in one of the systems. Obviously, if it's gestational diabetes, like we said, that sugar doesn't start going up until the second trimester. So those mothers that develop gestational diabetes aren't really at increased risk of having actually malformed organs and systems, unless of course they really were diabetic all along and we didn't really know about it. Frequent abnormalities we see are cardiac malformations, for example, just a hole in the heart like a VSD or an ASD, or like a cyanotic congenital heart disease, and a TGA or transposition of the great arteries or great vessels is the one that we're at least tested on the most. Babies are at increased risk of having neural tube defects, so like a myelomeningocele or a meningocele or even like an anencephaly, and they're also at increased risk of having caudal regression. I've never seen a severe case of this, but I've seen a couple of like pretty mild cases. The good news though is that if pre-diabetic mothers, so mothers who are diabetic, if they control their sugars before they get pregnant and into their first trimester, then these babies are at no increased risk of developing any malformations. So good sugar control before and during pregnancy is absolutely paramount. What about long-term effects of these IDMs? Well, unfortunately, they do have an increased mortality rate, probably a combination of the increased risk of the HIE as well as the malformations that they may be born with. They all are also at risk of increased morbidities in the future, even when they leave the hospital. Like all follow-up studies, this is really difficult to tease out, but it is thought that IDMs are at increased risk of having metabolic issues in the future. So things like obesity and cardiac disease. And there's also been some suggestion that they're at increased risk of having cognitive issues as well. Again, I don't know how much of that is secondary to actually the pregnancy status. 2, let's talk about pregnancy-induced hypertension and pre-eclampsia. Pre-eclampsia is the combination of hypertension and proteinuria, so a lot of protein in the urine. Eclampsia is when you've got all of those things and it's so bad that the mother actually starts seizing. Pregnancy-induced hypertension is also really common in pregnancies. It affects 6 to 8% of all pregnancies, and it is very severe in less than 1% of pregnancies. If preeclampsia and eclampsia are not treated, then they can have a very high mortality rate for both the mother as well as the baby. And that is because the high blood pressure and the risk for seizures is actually coming from the placenta. So often if the mothers really are sick, then they need to deliver and get that placenta out so that the mother's high blood pressures and risk for seizures can be put under control. Often the placenta is small and not functioning well, and obviously that's going to affect the fetus. These placentas are often not providing the nutrition and the oxygen that the growing fetus needs. So often these babies end up being really small or small for gestational age, or their weights are less than 10th percentile for their gestational age. In fact, one of the most common causes for actually delivering an SGA baby is having some sort of maternal hypertension or placental issue. These fetuses are pretty smart in utero, and basically what their bodies try to do is try to make sure that as much of the oxygen and the nutrition is still getting to the brain. So these babies may have head-sparing IUGR or SGA status, which means that relatively their head is a larger percentile than the rest of their body. So for example, these are babies where you could plot out all the growth parameters and the baby's weight is like 8th percentile. So obviously SGA, because it's less than 10th percentile, the length might be like 12 or 13th percentile or something. And then the head, when you plot it out, is like 35th percentile. So they look like little scrawny babies with nice big heads. Obviously, if the severe issues with the placenta started earlier in pregnancies, these are women that have like high blood pressures at like 20 weeks or whatever, then those babies are much more likely to just be tiny all over, including their heads. Interestingly, there used to be this thought process that any infant that was relatively under stress during pregnancy, so like trying really hard to get all the oxygen it needs, whether it was, for example, a baby born to a mother with PIH, or whether the mother had chorioamnionitis or something, it used to be thought that a little bit of stress for the babies was a good thing because it kind of encouraged the steroids to increase in the babies. And so these babies came out like a little bit stronger and more mature. But now we realize that really this stress might be better kind of acutely for the baby, like the first few days after life, but it doesn't necessarily have good long-term outcomes. So for example, in babies that are born small, especially if they're premature, their mortality goes up. Also, they're at increased risk of things like bronchopulmonary dysplasia, neck, pulmonary hemorrhages, ROP, really at increased risk of a lot of the 3-letter acronyms in the NICU. So being small really isn't a good thing for babies. To backtrack again, if you are a mother watching this and you have been told that your baby is on the smaller side, these are just slightly increased risks. The vast majority of these babies can still get home and do very well. What about lab values in babies born to mothers with PIH? Well, one of the things that we have to worry about in all SGA babies is the baby developing hypoglycemia or low sugar levels. And again, this is very logical. The babies are smaller, or their organs are smaller, and they don't have as much glycogen in their livers. So what does that mean? It means that if the babies aren't eating enough substrate, so they're literally not drinking enough milk, and their sugars are borderline, then they aren't able to break down the glycogen after a certain point to create more glucose for their bodies. So we check sugar levels in all babies that are born SGA. If they're preterm, we're checking them anyway. So whether they're preterm and SGA or just preterm, we've definitely got to follow sugar levels. Other abnormal lab values we see in babies born to mothers with high blood pressures or with issues with their placenta are abnormalities in the CBC. One of the most common things that we see is a high hematocrit or a relatively higher hematocrit. This is also really logical because, like we said, the placenta, by definition, it's small, it's not functioning well, is not providing the fetus with all the oxygen that it needs. So what is the fetus going to try to do to make sure that it's much better at carrying that oxygen around the body? It's going to ramp up its own red blood cells or ramp up its own hematocrit to try to make sure that all the cells in the body is still getting the oxygen that they need. And then the other cell lines are much more likely to be lower. I always like to think that it's because the bone marrow is so busy making the red blood cells that it literally doesn't have time to make the white blood cells and the platelets. So these are babies who are much more likely to be born with thrombocytopenia, so a platelet count of less than 150,000. And honestly, normally it's like in the 80, 90, 120K range. If the platelet count is like 8,000 or 15,000, then that's not going to be from the PIH or from being an IUGR baby. If it's that low, then it's some sort of like platelet breakdown process happening. And they're more likely to have a leukopenia or a WBC count of less than 5,000 and a neutropenia, so an absolute neutrophil count of less than 1,500. Those are all really classic CBCs in a baby that was born to a mother with PIH. I just want to make a really quick clinical point here. Sometimes you admit a baby with SGA to the NICU and you end up getting a CBC and you see that the baby does have thrombocytopenia. Make sure that you go back and find out whether the mother did have pregnancy-induced hypertension or whether the placenta was found to be small or whatever at delivery. If you can get that history from the mother's chart or the records or whatever, then you can feel better about this as an explanation. Yes, the mother had PIH and that's why the baby is small and we have borderline platelets. But if you can't find that history and the mother is like, no, my blood pressures were always great or stuff, then the other big thing that you need to consider is a torch infection. We filmed a couple of videos on that. Go back and watch it if you want. But think about especially CMV, cytomegalovirus, or syphilis. So a small baby with thrombocytopenia might not just be PIH, it might be other things, including a torch infection. So consider that. One more thing I want to mention is that often mothers with PIH or pre-eclampsia are placed on magnesium, the drug magnesium, in an effort to lower their blood pressures and to decrease the chance of them actually developing a seizure. That magnesium can travel through the placenta, and babies whose mothers were exposed to magnesium, the babies can be born with really high mag levels too. In babies, the high magnesium level can make them like really floppy at birth and also cause respiratory depression. So basically even apnea. So sometimes these are babies, even if they're otherwise completely healthy, they come out and they've got no interest in breathing at all. Sometimes you just have to intubate them for like a few hours until they start to get that magnesium out. And the magnesium can also slow down peristalsis. So sometimes it takes a little bit of time for these babies to start actually tolerating these feeds and actually pooping, whether it's a full-term baby or whether it's a preemie baby. The magnesium is urinated out. So as long as the baby's peeing fine, eventually the magnesium will go back down to a normal level. Like a lot of other follow-up situations in neonatology, it is really difficult to tease out exactly the outcome of these babies born to mothers with pregnancy-induced hypertension or pre-eclampsia, and basically actually figure out how much of their outcomes were made responsible by what happened during pregnancies. Some studies have shown that these babies, as they grow up, are at increased risk of metabolic diseases, increased risk of diabetes and growth issues and obesity. And also during childhood, they may have an increased risk of hospitalizations from all types of things, neurological issues, from malignancies, from infectious diseases. Again, difficult to tease out whether this is because they were just born small or whether it's more related to like the actual hypertension during pregnancy. 3, PPROM, or preterm premature rupture of membranes, or basically when the water breaks or when the membranes rupture before 37 weeks and before they're supposed to, so the mother isn't going into labor or anything. And we've all seen these mothers. They come in at 18 weeks or 24 weeks or 34 weeks and they complain of having leakage and they are not in actual active labor. A lot of times when they first come in, the OBs aren't sure if the membranes are actually ruptured, but they can do some testing and then they confirm it. So if a mother really does have a PPROM, then what should we actually be worried about? There are 3 things that we worry about if the mother had PPROM. The first one is obviously if the mother is ruptured, we're a lot more concerned about that mother going into labor and delivering a baby prematurely. So much higher risk of premature labor and delivery. The OBs will give mothers that have had PPROM, if they have PPROM less than 34 weeks, they'll give them a 7-day course of antibiotics, latency antibiotics, hoping that they can kind of stretch out the time between the PPROM and actually delivering the baby. As you all know, though, we're all not very successful at preventing premature deliveries. And it's always quoted that if a mother does have PPROM, then there is a 50% chance of that mother delivering in every subsequent week. So, for example, if the mother had PPROM at 25 weeks, 50% of those will deliver by 26 weeks. 50% of the remaining will deliver by 27 weeks. So basically 75% of all those mothers will deliver by 27 weeks. And then another 50% by 28 weeks. So basically most mothers that have had PPROM are going to deliver between 3 to 4 weeks. Obviously, we all know about the exceptions, the mothers that sit in antepartum for weeks and don't end up delivering until 34 weeks. We love those, especially when the babies come out healthy. The second risk factor with a PPROM is the risk of an infection, or more specifically, a chorioamnionitis. If the membrane that is protecting the baby and the amniotic fluid and the placenta from the outside world is broken, which is obviously what rupture of membranes is, then there's a much higher chance that bacteria from the outside world can ascend up the vaginal canal and enter into the amniotic sac and the uterus and actually cause an infection, or what we call chorioamnionitis. The body is very clever if the mother ever develops chorioamnionitis. It will do everything that it can to push the baby out to make sure that that baby is saved. Because if that baby is swimming around and infected amniotic fluid, then that baby is not going to make it. So if the mother develops chorioamnionitis, then basically that mother is going to go into labor and end up delivering that baby. Not just that, the baby will be preterm if obviously this happens before 37 weeks, but also babies that are delivered through chorioamnionitis are much more likely to be infected themselves. And even if we can't actually grow a bacteria from their bloodstream or wherever, then those babies generally do have increased morbidities moving forward as well. So the combination of a mother with chorioamnionitis and a preterm delivery is not good at all. The third complication of a PPROM is probably not one that we talk about as much, but truly it's the thing that affects the babies the most. And that is pulmonary hypoplasia, or underdevelopment of the fetal lungs. What ends up happening is when there is premature rupture of membranes, often there's like a steady leak of the amniotic fluid to the outside world. And because of this continual leak of the amniotic fluid, the fetal lung fluid, which the fetus lungs are actually making, the fetal lung fluids is always leaving the lungs to contribute to this ever disappearing amniotic fluid. So often these fetal lungs have very minimum fetal lung fluid. So with low or absent amniotic fluid, we have to assume there's really no fetal lung fluid in there at all. These lungs do not develop. We need to have good fluid in the amniotic sac for the fetal lungs to develop well. If there isn't enough fluid, then the lungs stay really, really small and they stay hypoplastic. The severity of the pulmonary hyperplasia, logically, will depend on how long the mother has been ruptured for and really how much amniotic fluid there was. So, for example, if you had a mother that ruptured at 19 weeks and is sitting in antepartum but literally has like no fluid at all in the uterus, and then the mother ends up delivering at 30 weeks, those lungs are going to be so tiny and so stiff. Often it's impossible to oxygenate and ventilate these babies. You're intubating them, putting them on really high settings on the oscillator. Often they end up needing chest tubes because their lungs are sticky and they burst as we're trying to give them higher pressures. Often we're putting them on nitric oxide because they develop pulmonary hypertension so quickly, but it's kind of a fixed type of pulmonary hypertension. So often the nitric oxide doesn't really help that much. These are very, very sick babies. And honestly, tragically, a lot of times, if they really were swimming around in absolutely no fluid, then often there's literally nothing that we can do to make these babies survive. Even if it's not this extreme, even if the mothers did have a little bit of fluid during pregnancy, then generally we still know that these lungs are not going to be formed as well, and they really are going to be at a much higher risk of developing BPD or even more immediately developing pulmonary hypertension. So this really is probably the most important thing to emphasize to mothers during the prenatal consult if the mothers do have PPROM. Sometimes, really rarely, and I don't really understand how this happens, even after mothers have been diagnosed as having a PPROM, then their membranes, quote, reseal. I'm not really sure what that is. And basically the fluid and everything is fine in there. Obviously, in that case, we can be a lot more optimistic. Or if the mother is on bed rest and for whatever reason, it's not like a gushing leak and there's still good fluid in there, then again, we can be more optimistic about the status of the lungs. But still, I always really, really worry in the delivery room of mothers that have had PPROM for a long period of time. 4, let's talk about maternal anxiety and depression. Pregnancy-specific anxiety is extremely high in the first and third trimesters, and I think we've all been there. But overall, the incidence of maternal anxiety and depression during pregnancy is similar to non-pregnant women. So it's about 10 to 13% of all women. So again, actually really high. Babies born to mothers with untreated depression are much more likely to be born premature. They're much more likely to have a low birth weight, to have IUGR. And even as they go into childhood, if the mothers are untreated for depression, then they're much more likely to have actual developmental delays. And logically, if the mothers have depression and they remain untreated, then obviously that is very, very detrimental to their health and safety and well-being too. Untreated pregnant mothers with depression are much more likely to have increased hospital admissions during their pregnancy with complications like with pre-eclampsia. Also, they're much more likely to engage in high-risk behaviors like alcohol or drug use, or just have very, very poor nutrition and poor weight gain during their pregnancies. And logically, they're going to be at an increased risk of developing postpartum depression as well as suicidality. To prevent all these things, it's important to put depressed pregnant mothers on antidepressant medication or anti-anxiety medication. And a lot of mothers in the past have been very reluctant to take these medications just because they're worried about any adverse effects that it's going to have on their fetus. Remember, though, that untreated depression is going to have bad effects on the baby as well. Large studies have suggested that various antidepressants, and each one has kind of a slightly different incidence, may slightly increase the risk of some abnormalities if they're taken in the first trimester. So, for example, cardiac abnormalities like a coarctation or a VSD, also just kind of GI abnormalities like a gastroschisis. But again, this really hasn't been categorically proven, especially in the vast majority of antidepressants and anti-anxiety medications. If a woman was on an antidepressant medication and she just decides to stop it during pregnancy, then those mothers are at massive risk of having depression relapses, a lot of them actually needing hospitalization. So just stopping an antidepressant when you're pregnant is just not a good idea at all. So really, if the mother is on an antidepressant medication, then we really shouldn't worry a lot about any abnormalities that may be causing in the fetus. There are no tests or anything else that we'll be doing just because the mother is on a medication. What we should be concerned about if we are seeing a newborn to a mother that was on an antidepressant is any type of kind of mild withdrawal symptoms that baby may have. For example, if a mother has been on benzodiazepines, then after birth, normally within like the first couple of days, the baby might start showing withdrawal symptoms. So things like crying a lot, jitteriness, poor feeds, agitation, poor sleep. If it's considered bad enough, then we should be treating these babies with like a tapering dose of a benzodiazepine to try to get them over the hump of the withdrawal. If the mothers have been on SSRIs, so selective serotonin reuptake inhibitors, things like fluoxetine or sertraline taken for depression and anxiety and everything, then one of the withdrawal type or the effects that we need to look for in the neonate is respiratory symptoms. And actually, these babies can have some pretty significant respiratory symptoms. These babies may present with a pulmonary hypertension type picture, and you can't really explain why they're needing so much oxygen. So just kind of think about this in the differential diagnosis. Was the mother on any of these medications? Sometimes the symptoms are more subtle and they'll look more like a kind of TTN picture. So the baby just has a little bit of increased work of breathing, maybe a bit of a hazy x-ray, maybe just needs a little bit of a respiratory support. These babies also may have slightly increased risk of hypoglycemia. A lot of this is thought to be maybe secondary to kind of just poorer feeding or just the baby's not feeding as well. So obviously with any of these symptoms, and if a baby is jittery, then you're going to be checking the sugar levels anyway. There isn't any real treatment for the respiratory symptoms or the kind of withdrawal of the SSRIs. You just have to clinically support the baby through it. So the respiratory support or IV fluids. Obviously, if the baby is really, really agitated, then you could try giving a benzodiazepine or something to just kind of calm the baby down. But you're not really worried about a dangerous level of withdrawal in these babies. It's not like the neonatal narcotic abstinence syndrome or anything like that, where if you really do let these babies withdraw, then they could end up with seizures and just being very, very sick. Again, though, I want to emphasize that this is a very small percentage of all these mothers. Just something for you to think about in newborns that have been exposed to those drugs. Okay, that was it. I hope that was helpful for you. Just a few tidbits. Obviously, there's a lot more information on all 4 of those disease processes, but I just wanted to kind of really emphasize what's going on in the babies. If you got this far, please like this video and please come join our channel membership so you can let us know which video you'd like to see next. Thanks again so much for being here.